name is Charlie, and I'm going to talk to you a little bit today about taking care of clients with burns. Now, you're going to see that the information that we cover in this section is going to come directly from your understanding of fluid and electrolytes, especially understanding fluid volume deficit. Now, let's begin with occurrences. The risk of death increases in the very old and the very young. The very old and the very young. Now, let me explain. If someone who is really old or really young is burned, the risk of death is greater. Now, why is that the case? Let's first think about a child. It all goes back to understanding body surface area. I'm sure you remember the rule of nines. For example, if I burned my entire left arm and a baby had the same burn on their left arm, which of our burns covered the greater surface area? The baby, that's right. The greater the body surface area affected, the greater the chance that person is going to die. So that's why body surface area is so important. Now, think about the elderly person. The older we get, the less sub-Q fat we have. So when an elderly person is burned, the burn can go deeper. The deeper the burn, the greater the chance of death. That's why the very old and the very young have a greater chance of death when burned. Now also, the elderly client's state of health often makes healing more of a challenge. Impaired function of the heart, the lung, nutrition, and any chronic illnesses can complicate the recovery process for a burned elderly client. Now, where do most burns occur? Now, I'm not talking about where on your body. I'm talking about location. That's right, at home. Most burns occur at home. So that's why you've got to think about safety considerations. For instance, if you've got pot handles on a stove, which direction should the pot handles be turned? You want to turn them in, that's right. And don't forget about irons, curling irons. All those things can cause serious burns, especially for children. If you've got the drop-in type stove, remember those things need to be attached to a wall because there have been cases where children have actually pulled those over on top of them. If toddlers are in the home, tablecloths should not be used because you know they're going to pull them off, pull something hot off the table and could burn themselves. So having children or elderly family members in a home also requires that you check your water heater temperature. You don't want it set more than 120 degrees. Remember, what about your elderly person with neuropathy? Could they get into a tub of water that's too hot and burn themselves? Right. Children could also get a burn from getting into water that's too hot. So you've got to be very careful with hot water. Now, with children, you have to think about keeping electrical sockets covered. So you see there's a lot of safety considerations that we have to think about to prevent burns. Now let's look at the pathophysiology. That's next. After a burn, many different pathophysiological changes occur, and I want to focus on why they occur. Remember, why is the important question you've got to ask yourself, because why is the question that's going to enable you to read the NCLEX question, apply critical thinking, and understand something, and therefore get the application question right. And you know, we're all about getting more questions right than wrong. So now, let's focus on why. First of all, why does plasma seep out of the tissue? I bet your teacher told you something about increased capillary permeability. Increased capillary permeability. Now, when I say something is permeable, I mean it's leaking. That's what the vessels are doing when somebody has been burned. The vessels are leaking. Their vessels are leaking because they've been damaged from the heat. So think about it. If your vessels are leaking, the vascular volume is going down. So tell me, could this person go into shock? Absolutely. Now, when does the majority of leaking occur? During the first 24 hours. The first 24 hours. Now, do you understand why the first 24 hours are a critical time for the client? Fluid volume deficit. We're talking about shock here. If you understand fluid volume deficit, you'll get the following questions right. Now, why does this person's pulse increase? Anytime somebody has a fluid volume deficit, their pulse is going to increase. Anytime you have a fluid volume deficit, your pulse is going to increase. So the heart rate, remember, has got to increase to pump what little bit of blood remains out to the vital organs. Now, why does the cardiac output decrease? Well, there's less volume. Less volume is being pumped out. If there's not as much volume in the vascular space, then the cardiac output is going to go down. Now, why does the urine output decrease? Well, there are two reasons. And remember, we discussed this with fluid volume deficit. The kidneys are either trying to hold on to any amount of fluid that they've got left, or they're not being perfused. So they're trying to hold on to the amount of fluid that they have left, or they're just not being perfused. Now, that can be very dangerous because remember, it only takes about 20 minutes of poor kidney perfusion for someone to have permanent kidney damage. Now, next, why is epinephrine secreted? Let's think about this. Initially, when somebody is badly burned, the heat is going to cause them to vasodilate, which bottoms out the blood pressure. Now, initially I said, but you know you've got those fight or flight hormones, the stress hormones that are available. Remember epinephrine and norepinephrine. Epinephrine is going to be secreted into the body, which is going to cause a vasoconstriction. So epinephrine is going to cause vasoconstriction, which will cause the blood to be shunted out to the vital organs. So that vasoconstriction will also help the blood pressure go back up. So you see there's a minimum of blood pressure needed in order to perfuse the vital organs. Anytime the blood pressure drops below 90, the person won't have adequate perfusion, and that's very dangerous. Now, I bet everyone here can answer the next question. Why are ADH and aldosterone secreted? Discuss that with your friend for a second. Now, I bet you already know that answer. You retain sodium and water with aldosterone, and you retain water with ADH. Now, therefore, ADH and aldosterone are going to make your blood volume go up or down? Up. So blood volume would be replenished, and that's a good thing in this situation. Now, let's look at some of the miscellaneous information. Look under airway injury. What's the most common airway injury? Carbon monoxide poisoning. All right, now read with me. Normally, oxygen binds with hemoglobin. Now, carbon monoxide travels much faster than oxygen. Therefore, we've got to get, and it gets to the hemoglobin first and binds. When oxygen gets there, can it bind now? No. There's not any place for it. Now this client is hypoxic, right? And the treatment for hypoxia is oxygen. And in this case, we're going to give 100% oxygen. Why are we going to give 100% oxygen? Well, we want to give 100% oxygen to someone that we suspect has a carbon monoxide poisoning because we're putting more oxygen out there to get in the race to get to the hemoglobin. So by putting more oxygen in the race, we're increasing the probability that oxygen will get to the hemoglobin before the carbon monoxide. Now, don't be surprised if this person has good color. In fact, they could be cherry red. But guess what? They still need oxygen. Yeah, now based on this information, you think it would be important to do you think it would be important to determine if the burn occurred in an open or closed space? Well, yes, it's very important. If somebody is burned in a closed space, they will have inhaled more carbon monoxide. So they're going to be at greatest risk for airway injury. Now, an airway injury will always cause the most concern. So let's move on to the next statement. When you see a client with burns on the neck, face, or chest, you better be thinking about their airway. Now, if the client has numerous upper body burns like neck, face, chest, you've got to be carefully monitoring for breathing problems, right? In regards to their airway, what might the doctor do prophylactically? Ask your friend. Now, if you said trach, let's hold off on that for just a little bit, okay? If I'm your client, let's try the ET tube first. Try to intubate before you get your trach kit out. Now, why did I say intubate prophylactically? What do we expect is going to happen with the airway? Yeah, it's going to close off or swell. And if we wait too long, the airway could swell so tightly that we can't get the tube in at all. The swelling is going to get worse over the first 24 hours after a burn has occurred, and then there may be no option but to trach the client. But try the ET tube first. Now remember, NCLEX rule, always go for the least invasive first. Now let's look at classifications of burns. A person has burned over 40% of their body. How do you think this was determined? Now, I've already mentioned it once. It's called, remember, the rule of nines. And I bet you remember memorizing the rule of nines. It's an estimate of total body surface area affected. Remember, it's only an estimate, so this estimate is done more than once. They'll do it as soon as the client arrives in the ER and then again in 2 or 3 days. After 2 or 3 days, there's clearer evidence of where the wounds begin and end. There's better demarcation. Now let's review the rule of nines. Let's see, the head counts for 9, each arm 9, each leg 18, the anterior trunk 18, the posterior trunk 18, and the only one that everybody consistently remembers all across the country, the genitalia. One little point. I don't care who you are, 1 point. All right, let's move on. Let's look at treatment. We're talking about burns here with greater than 20 to 25% of body surface area. One of the most important aspects of burn management is fluid replacement. Fluid replacement. Now, it's important to know, is it important to know the time that the burn occurred? Yes, because you know that fluid replacement therapy is going to begin during the first 24 hours based on the time that the injury occurred. The time that the injury occurred. Now, that's right. Not when treatment was started, but when the injury occurred. So if someone was burned at, say, 12 o'clock, and they don't get to the hospital until 2 o'clock, we've already lost 2 hours of replacement time. So you'll see what I mean in just a second. In this case, 12 o'clock would be the important time to remember. Now, read this next statement with me. A common rule is calculate the total amount of fluid needed for the first 24 hours and give half of that amount during the first 8 hours. So if I'm burned at 12 o'clock and I don't arrive at the hospital until 2 o'clock, I've already lost 2 hours of fluid replacement time. Now, half of the total fluid replacement must be given over the remaining 6 hours. The goal is to give half of the volume in the first 8 hours, okay? This is called the Parkland formula, and that's just one common formula that's available. The doctor's going to select which formula to use, but this is a common one that's seen. Now, in order to calculate fluid replacement properly, you've got to know the client's weight, and you also have to know the total body surface area affected. It depends on which formula is being used, right? So if the client is restless, it could suggest that fluid replacement is inadequate, it could indicate pain, or it could indicate hypoxia. It can indicate all three of those, right? So which of these possible causes do you need to address first? Which one takes priority? Hypoxia. Hypoxia, write that down. Worry about hypoxia first, okay? Hypoxia must be the #1 priority because that is the one that could kill your patient. Now you're catching on, right? Remember our NCLEX tip. The burn person could probably choose pain as their priority, and we would understand that. But there's an NCLEX rule that you've got to remember. Pain never killed anyone. Pain never killed anyone. Now, what do I mean by this? On NCLEX, you may get a question that asks, which person would you see first when you come out a report? And I promise you, one of your choices is going to be somebody in pain. Now, I'm not saying that this is not the first person you would see. What I'm saying is to be sure that the other 3 clients do not have life-threatening situations. You know, anything that's life-threatening needs to be dealt with right now. You have a little more time to deal with pain. Remember, NCLEX wants you to deal with a life-threatening issue immediately. Because what's this test about? Keeping people alive. You can ask another nurse to treat your client that's in pain while you deal with a life-threatening situation. Now, what I want you to understand here is that if you have questions about priority, always go back to Maslow's hierarchy of needs. And Maslow starts with oxygenation. All right. Which of the following would you select to determine if the client's fluid volume is adequate? Weight or urine? Discuss that with your friend. Okay, normally I would say daily weights. Normally I would say weights, but in this case we're going to make an exception to the rule. Urine output is going to be the correct answer in this case. One individual weight is never really going to tell you a whole lot. Daily weights are going to tell you much more. But what you've got to think about in this particular situation, the person who's been burned is going to be receiving a lot of fluids rapidly. Now, receiving fluid rapidly is going to naturally make one's weight go up. In this case, the weight gain won't really help you determine adequate fluid replacement, but the urine output will. So urinary output, remember, it needs to be a minimum of 0.5 milliliters per kilogram, which is usually around 30 to 50 milliliters per hour in the adult. In children, we want a minimum urinary output of 1 milliliter per kilogram. So for those with burns, we need to focus on the urine output, okay? So be sure to circle urine output. Now, I would normally say 99% of the time, weight is an excellent indicator of fluid volume status, but not with somebody that's been burned. Now, this is a good place to stop and talk about another type of alternate format question. Fill in the blank. Okay, now take that look of horror off your face because I know what you're thinking about, all the difficult words that you're going to have to need to know how to spell to get a fill in the blank question right. Well, good news. These will only be calculation questions, and the answer will be numbers and decimal points, no words. So here comes one of our most frequently asked questions. What rules do you follow for rounding off on the NCLEX? More good news. You just have to remember one rule. Round off at the end. See, that isn't so scary. Each question will tell you exactly how many decimal points they want you to carry out the answer to. They'll say record your answer using one decimal place. So you'll open up your little calculator box, work the problem, and round off at the end. Simple. You don't even have to know the unit of measure. They're going to tell you milliliters per hour or milligrams per milliliter. In fact, if you try to put any other characters in the box, it's going to tell you, try again. So here's your question. Follow along with me in your book. A client weighing 235 pounds has a 30% total body surface area burn. The physician's prescription is titrate the IV fluids to maintain urinary output at 0.5 milliliters per kilogram per hour. What is the desired output? Record your answer as a whole number. So, you and your friend work the problem in your book together. All right, so your answer is 53 milliliters per hour. So let's talk about how we got that answer. We know that there are 2.2 pounds per kilogram. So we divided 235 by 2.2 pounds per kilogram, which gave us 106.818181 kilograms. Now I know you wanted to round that big number off, but when do we round off? At the end. So we multiplied 106.818181 kilograms by 0.5 milliliters per kilogram per hour, and that gave us 53.409. But what did the NCLEX lady tell you to do in the STEM? She said to round off to the whole number. So the answer is 53 milliliters per hour. Now, emergency management. Look at your book. A person is wrapped in a blanket to stop the burning process. Since the flames are gone, does that mean that the burning process has stopped? No. What else could be done to stop the burning process? Yeah, cool water. Ice water? No, we don't like ice with burns because ice causes too much vasoconstriction. You don't want to cause vasoconstriction to a burn. This will inhibit blood flow to the wound. So remember, cool water, once the flame is extinguished, will soak the burned area and adherent clothing with cool water. Now, will the blanket provide any additional help? Well, the blanket will help hold in body heat. Body heat. Remember, when someone is badly burned, they've lost their skin, the number one thing that they'll have to help them to maintain their body temp. So now you have someone who can become hypothermic. Body heat can be held in with the blanket, so keep them warm. The blanket will also help to keep out germs. Yeah, that's right, germs. So why is it important to remove jewelry? Because swelling is going to occur. We also know that the metal gets really hot and continues to burn. Now, don't forget any jewelry in a pierced body part as well. Now, remove non-adherent clothing and cover the burns with a clean, dry cloth. Now, we know that now is not the time to debride a wound, so don't remove any clothing that's stuck in the burn. You should just remove any non-adherent clothing because it can constrict blood flow if any swelling is occurring. So what are some indicators that an airway injury has occurred? Ask your friend. All right, yeah, things like singed nose hair, singed facial hair, soot, black stuff all over the face, coughing up stuff with dark specks or secretions that could be really black, blisters found in the oral or pharyngeal mucosa. Are there more deaths with upper or lower body burns? Upper, because of the effects on the airway. Now, the client's respirations are shallow. What are they likely retaining? CO2. That's right, CO2. Now, therefore, what acid-base imbalance will they likely have? Respiratory acidosis. You know that because you just learned that in the acid-base section, right? Now, medication management. Let's talk first about albumin. You may or may not administer albumin. It depends on the protocol at the burn center. But if it is given, there are some principles that you need to understand. You need to know that albumin holds on to fluid in what space? The vascular space. Yeah, albumin holds on to fluid in the vascular space, okay? And this will increase or decrease the vascular volume. Right, it's going to increase their vascular volume. And how is this going to help with kidney perfusion? It will increase kidney perfusion because now they've got more fluid returning to the vascular space, therefore more fluid to circulate. Now, what will this increased volume do to their blood pressure? All right, it's going to increase it. It's going to increase the blood pressure. More volume means more pressure. Now, what will happen to the cardiac output? It's going to increase cardiac output because they've got more volume in the vascular space to circulate. Now, will this help their fluid volume deficit? Yes, because where are we putting more fluid? In the vascular space. So yes, this is going to help correct their fluid volume deficit. Now, when you start giving a client albumin, you've got to remember their vascular volume will increase. What will this do to the workload on the heart? Well, it's going to increase the workload on the heart because there's more volume to pump. Now, increasing volume is okay to a certain extent, but remember, things could get worse. If you stress the heart too much, you know that this person could be thrown into a fluid volume excess. Now, if this occurs, what's going to happen to their cardiac output now? If they go into a fluid volume excess, their cardiac output is going to begin to decrease because the heart's being stressed out and it can't pump as well. So basically, the heart's wearing out and it's beginning to fail. So if your cardiac output is going to be decreased. Now, how will the lungs begin to sound? Right, they're going to sound wet. The lung sounds are going to become wet because the heart isn't pumping volume forward, it's going backwards into the lungs. Now, what measurement could you take hourly to help ensure that a rapid fluid infusion is not overloading your client? Remember, notice the hint, your heart. Ask your friend. All right, since hint was heart, I know that you didn't say urine output now, did you? No, you didn't say that. You said CVP. That's right, CVP. Now let me explain. If you give fluids too rapidly to someone, you better hope that you've got a central line to help measure the CVP. The CVP will allow you to look at the right atrial pressure. So if the CVP number goes up too rapidly, then you're creating a fluid overload. In other words, all you're doing is filling up the right atrium really fast. So if the number increases too quickly, it doesn't mean that the person has a total body hydration. It just means that you've filled the right atrium with fluid, which made the number go up. So you could create a right-sided heart failure. Now, remember these principles will apply to anybody receiving colloid or hypertonic solutions. Okay, now, pain medicines. A client has an order for morphine that states morphine 2 milligrams IV push or morphine 4 milligrams IV push Q2 hours PRN for pain. If the client is complaining of pain 4 on a 10 scale, which dosage would the nurse give to the client? Yeah, you want to give 2 milligrams of morphine IV first. Remember the rule, you want to give the smallest amount of narcotics necessary to relieve somebody's pain. Now, when you're given a narcotic, especially IV, what's the most important assessment that you've got to make? Yeah, respirations. Remember, you got to count those respirations. Now, in the burn client, why are IV pain medicines preferred over IM medicines for burns? Well, they act quickly. They're going to get there quickly. And also, for an IM to work, remember, you've got to have adequate perfusion to the muscle. And if you've got somebody who's badly burned, you don't have that. Okay, immunizations. Since burns are considered a contaminated wound, a tetanus toxoid booster is given. But what if prior immunization has not been given, or if it's been more than 10 years since they've had a shot, or if the client really can't remember when they had their last shot? Then we've also got to give the tetanus immune globulin. Now, let's talk about tetanus toxoid. This is a good time to talk about active and passive immunity. I'm going to use tetanus as an example. When you give a tetanus toxoid booster shot, you're causing them to produce their own antibodies. It takes 2 to 4 weeks for them to develop their own antibodies. So does their body have to work? Yes, their body's got to work to make antibodies. That's why it's called active immunity. Okay, now let's look at passive immunity. Immune globulin is given when the client needs protection from tetanus today. If the client's uncertain about his tetanus shot history, we don't know if they've got any antibodies to boost, so they need additional protection. If you give a tetanus toxoid shot today, the client will not have antibodies today. So that's why you've got to give them the immune globulin to cover that person during this window of time when they're producing their own antibodies. Anytime you give a shot of immune globulin, think immediate protection. Immediate protection. You're actually injecting that person with antibodies. You're giving them the antibodies. If you see a vial of medication that is labeled hepatitis immune globulin, remember that contains antibodies. This person needs immediate protection. That's why we call this passive immunity. Their body didn't have to work for the antibodies. They were given the antibodies with the injection. All right, let's move on. Let's look at some complications of burns. As we go through the next few questions, I want you to think about circulation. If a person has a circumferential burn on their arm, first of all, what does circumferential mean? That's right, all the way around the arm. It could cut off their circulation, all the way around the arm. So what do we need to be checking? Circulation. Now, write down everything that's included in a circulatory check. Everything that you can think of for a circulatory check. Are you writing them down? All right. Now I'm going to share the top 5 answers that I usually get. Pulse, skin color, skin temperature, capillary refill, and turgor. Now out of these 5 things, which one is wrong? Turgor. That's right. It sounded reasonable, right? For just a split second, yeah, but even if you're not admitting it right now, somebody in the class thought it was very reasonable. Now, when turgor is assessed, what does that determine? Hydration. Hydration, yeah. So turgor is a hydration check, so don't think of it as a circulatory check. Now, somebody probably wrote sensation on their list. Sensation is another good circulatory check, but I usually reserve sensation for a neurovascular check on an orthopedic client. I don't want you to get that confused because sometimes it'll make you miss questions. So from this point forward, in this class, when you hear me say check circulation, the 4 things you should check are pulse, skin color, skin temp, and capillary refill. Pulse, skin color, skin temp, and capillary refill. Now, read with me. If a person's vascular check in their arm is bad, what is the name of the procedure that will relieve the pressure? Well, you've got a couple there. Eschariotomy, it relieves pressure and restores circulation. The eschariotomy relieves pressure and restores circulation. Or also the fasciotomy. It's also going to relieve pressure and restore circulation. But the cut is much deeper into the tissue with a fasciotomy. Now, let's shift gears a little bit. Let's look at renal complications. All right, a Foley catheter has been inserted to allow you to measure urine output. How often will you need to monitor their output? Every hour. Now, is it possible when you inserted the catheter that no urine returned? Yeah, it's possible. Now, there are 2 reasons that this could happen. See if you remember the 2 reasons. Well, remember fluid volume deficit. First of all, the kidneys are trying to do what? They're trying to hold on or conserve and retain what little bit of fluid remains. And the kidneys also may not have adequate perfusion. So they're either trying to hold on and conserve, or they may just not have adequate perfusion. Now, what if the urine is brown or red? Well, first of all, I want you to know something. This is normal after a burn. But are we still going to worry about it? Yes, we're still going to worry about it. Let's think about this. When someone has been badly burned, they have muscle and tissue destruction, which releases myoglobin. The only way that myoglobin can escape from the body is through the kidney, okay? Now, that's what we're worried about with the red and brown urine. The damaged cells are being removed from the body, but they could clog the kidneys. So for this reason, I'm worried about the possibility of renal failure. So you've got to inform the doctor because we want them to initiate prompt treatment to hurry up and flush out the kidneys. Now, What drug might be ordered to flush out the kidneys? Mannitol. Mannitol. Mannitol is a diuretic. Now, diuretics are not normally given to a burn client because we didn't want to decrease the cardiac output for this client. This is the exception to the rule because the goal is to save the kidneys. So put a big star by this, exception to the rule. Now, in addition to giving mannitol, you may have to increase fluids and carefully watch their urine and report when it turns clear. Now, if there's no urine or the urine output is less than 30 milliliters per hour, what should you start worrying about? Same thing, kidney failure. Now, after 48 hours, the client should begin to diurese. Why is that? Well, fluid is returning to the vascular space, and now we've got to worry about a fluid volume excess. Remember, all that fluid is coming back to the vascular space. Now, what should naturally happen to the urine output at this time? Yeah, it's going to increase if the kidneys are still working. The urine output should increase if the kidneys are still working. Now, the next question talks about electrolyte imbalances. Okay, the client's serum potassium level is 5.8. Where should we find most of our potassium? Inside or outside of the cell? Okay, inside. If someone has been burned, though, what happens to their cells? Well, yeah, they rupture or they lyse. So what happens to the amount of potassium found in the serum? Yeah, it's going to increase because when those cells rupture, potassium is also released into the blood. Therefore, you better monitor this person closely for which electrolyte imbalance. Is it hypo or hyperkalemia? Hyperkalemia, yes, hyperkalemia. Okay, now questions about GI complications. Why do you think Mylanta, Protonix, Pepcid have been ordered for this patient? Well, to hopefully prevent a stress ulcer. And what's the name of that stress ulcer? Yeah, Curling's ulcer. Curling's ulcer. That's the stress ulcer. Now, we've listed for you in the box other specific antacids, H2 agonists, and proton pump inhibitors that might be used as well. Why do you think the doctor wants to wants this client to be NPO and have an NG tube connected to suction? Well, they can develop a paralytic ileus. Now, let's talk a little bit about that. Anytime you have a client with a paralytic ileus, they're going to have an NG tube connected to suction. If they have an ileus, you understand that gastric secretions are going to build up in their stomach, and this person could vomit and aspirate. Okay, so ask your friend 3 reasons why this client with a burn might develop a paralytic ileus. You're looking a little confused. Let me help you out. Number 1, just with a decrease in vascular volume, If you've lost vascular volume, where is the last place that's going to get perfused? Your gut. Yeah, your gut's not a vital organ. Now, another reason, number 2 reason, it's part of the normal stress response of your body. During times of stress, your GI motility shuts down. Another reason could be due to hyperkalemia. Now, although it's not the main reason, it can still have an effect. Remember, one sign of hyperkalemia is muscle weakness. Intestines are smooth muscles, aren't they? Yeah, so once again, the main reason for the ileus is likely due to the lack of blood volume and the stress response. Now, if the client doesn't have bowel sounds, what will happen to their abdominal girth? Yeah, it's going to increase. Now, do you think they're going to need more or less calories than before? More calories, because they're in a hypermetabolic state. Now, they also need 2 things in their diet for maximum nutrition. What are those 2 things? Things like protein, vitamin C. Protein, vitamin C. Always remember to maximize nutrition, think protein and vitamin C. Now, the NG tube will be removed when you hear bowel sounds. Yeah, and this tells you that peristalsis has returned. Now, when GI feedings are started, what should you measure to ensure that a supplement is moving properly through the GI tract? Yeah, residuals or gastric residuals. Now let's talk about residuals for just a little bit. Now, a common order for gastric residual is hold feedings if gastric residual is greater than 50. Now, let's pretend you aspirate from your client's PEG tube or NG tube and you get 75. What does this tell you about your client's peristaltic activity? Yeah, very slow, right? Very slow peristalsis. First, what will you do with that scheduled feeding? Well, you're going to hold it. But now you've got this big syringe full of stuff. What are you going to do with it? Well, give it back to them. You give it back because when you were checking the gastric residual, you pulled fluid, electrolytes, and acid. If you don't return it, you can throw this client into a fluid, an electrolyte imbalance, or even an acid-base imbalance. Now, name the lab work that would ensure proper nutrition and a positive nitrogen balance. Ask your friend that question. All right. You might have to say BUN. Usually when students hear nitrogen, they think about BUN. But remember, BUN is a kidney thing. I'm worried about nutrition here. So the answer would be prealbumin, total protein, albumin. Now out of these three, which one is the most sensitive indicator of overall nutritional status? Yeah, your prealbumin. All of us are normally in a positive nitrogen balance because we're well nourished. Anyone who's starving is in a negative nitrogen balance. So it could be somebody that's terminally ill, somebody with poor nutrition could be in a negative nitrogen balance. This person will need protein in order to improve nutritionally. Now, the last complication we'll focus on is integumentary system complications. Okay, if our burn client has partial thickness and full thickness burns, is it possible that they could have problems with contractures? Yes, especially with those third-degree burns. Now, let's look at the next statement. If the client has burns on their hands, what are some specific measures that we should take when you do their dressing change? Your teacher told you to do something with each finger. What was it? Yeah, wrap them separately. You want to wrap each finger separately. You don't want their fingers to grow together. Something else to remember, if my hand is badly burned as it begins to heal, what could my hand start doing? Yeah, contracting. So we've got to use splints to prevent contractures. Use splints to prevent contractures. Always splint an extremity in a normal looking position, okay? Now, if you've got somebody with burns on their neck, especially in the front, as it begins to heal, what could happen to their chin? Yeah, it could be pulled down toward their chest. That's why you need to hyperextend their neck. In other words, we want their head back. We don't want them to sleep on a pillow because that's going to also promote a contracture, that chin to chest type movement. So what do you think the number one complication is for someone with a perineal burn? Yeah, infection, infection, infection. Now, what is eschar? Yeah, that's that dead tissue. Eschar is dead tissue. And does it have to be removed? Yeah, it's got to be removed. If it's not removed, can new tissue regenerate? No, it's got to be removed so the new tissue can regenerate. Now, what else likes to grow in eschar? Yeah, bacteria. Now, let's talk some about treatment. What type of isolation do you think you're going to implement and maintain with a burned client? Remember what that one's called? It's protective isolation. Protective isolation. Now, normally when someone is on isolation, they've got something that we don't want to get, or they have something that we want to keep confined to their room, okay? But when someone is badly burned, they're severely immunosuppressed. So when someone is really, really, really immunosuppressed, then we've got to protect them. So we're protecting the client from all of us now. All right, Travase or collagenase. These are enzymatic debridement agents that eat necrotic or dead tissue. In other words, they debride. They speed up the removal of dead tissue from the healthy wound bed. Now look at the 4 things we have on your handout for these enzymatic agents. Don't use on the face. Do not use if pregnant. Do not use over large nerves. Don't use in an area that is open, that's an open body cavity. In other words, be careful. If you use them on the face, they're going to cause scarring. If you use them on an area that's open, it could cause some significant damage to internal organs. So be very careful. Now, hydrotherapy. Whirlpools are also used to debride. Whirlpools are used to debride. Now, what's the most important thing to remember before you send your client off for whirlpool treatment? Well, medicate them, yes. You want to make sure that you give them some medication and give it some time to kick in before you send them off to whirlpool because it can be very painful. Let's say that you're taking care of someone who's been burned on both arms and their left leg. Could they have different bacteria growing in each wound? Yes, they could. And what could happen if we take them and put them in the whirlpool? Yeah, they can get cross-contamination, and that's one of the biggest problems with whirlpool treatments is cross-contamination. Now, in your next section, there are several drugs. I don't expect you to memorize all of them. Just familiarize yourself with them. Silvadene, it's one of the most common one that people have heard of, right? The most important thing about drug therapy with burns involves this next question. Why should these drugs be alternated? In other words, we don't want to continue using the same drug over and over again because bacteria will build resistance or tolerance. The bacteria will build up resistance or tolerance. So broad-spectrum antibiotics are avoided to prevent what we call superinfections or secondary infections. Superinfections are secondary infections. Now, an exception, they're going to use broad-spectrum antibiotics until the wound culture has returned. Now, when someone is receiving a broad-spectrum antibiotic like gentamicin, what's it going to kill? Everything. Yeah, that's why it's called a broad spectrum. It kills everything. But the most important thing to remember before giving any antibiotics is to be certain that all the cultures have been collected and sent off to the lab for analysis. Now, I know you know this. Make sure the cultures have been collected before you start the antibiotics. And this is true for any culture from the body. So make sure you've got the cultures before you start the antibiotics, or you're going to mess up the cultures really, really bad. Now, since I said the word gentamicin, I've got to tell you something. Anytime that you see a word that ends in mycin, there are two things to worry about. Now, tell your friend, what are the two things that you're going to worry about with mycin drugs? Yeah, ototoxicity and nephrotoxicity. Oto and nephrotoxicity, the ears and the kidneys. Now, if you ever have anyone that's receiving a mycin drug and they have any complaint at all about their hearing, I don't care what it is, stop that mycin drug immediately because it can cause irreversible hearing loss. Now, how do you know if someone is becoming nephrotoxic? Well, you want to check their lab work for their BUN and creatinine results. If the BUN and creatinine are going up and their urine output is going down, they're experiencing kidney problems. You've got to assume that they're nephrotoxic. Stop the drug and call the doctor. All right, let's move on. But what if they need a graft? If grafting is done, first we remove the burned dead tissue until healthy viable tissue is seen. Then good skin is taken from a healthy donor site and placed over the burned area. Now, the donor site has become an open wound, so a transparent dressing may be placed here until the bleeding has stopped. Then the donor site can be left open to air. Now, if the client is well nourished, they can reharvest from the same donor site every 12 to 14 days. If the new skin graft turns blue or becomes cool, what would this indicate? Yeah, poor circulation, poor circulation. Now, sometimes the doctor will order for you to roll a cotton-tipped applicator, Q-tips, over the graft with a steady, gentle pressure from the center of the graft out to the edges. Why do you think that? Well, let me explain. Let's pretend that I've got a brand new skin graft, and you notice that there's something accumulating underneath. It might be air, blood, exudate, who knows what it is. Now this could prevent the graft from growing to the wound bed. So the doctor may use a Q-tip starting at the center and just kind of roll that stuff out from underneath. The doctor may take even like a tuberculin syringe and aspirate it too. But if you don't get the exudate or whatever it is out from underneath, the new graft is not going to adhere like it should, okay? So in caring for somebody with a skin graft, you want the graft to adhere. All right, before we move on, let me ask you this. Let's pretend I've got a brand new meshed split thickness graft on my left arm. And I've got a greasy dressing that's right next to the graft, then a middle and an outer dressing on top. And now you decide that you're going to come in and change the outer dressing. Well, you start unrolling it, and then you look away for a split second and turn back around and uh-oh, you've unrolled the entire graft and it's dangling by two sutures. Now tell your friend what you're going to do if this should happen. And it's not clock out, okay? Well, there's something you should know before you clock out. I know what you're thinking. Some of you wanted to look around and see who saw this, right? Yeah, stick it back. Or you wanted to roll it back up and hope nobody saw that this happened. This is bad. Don't do that. Mistakes are going to happen, and some of them are going to be bad. But you've got to confront your mistake, right, and be honest about it. So what do you need to do immediately is to put a sterile saline dressing over the graft so it won't dry out. Cover my wound up with like a dry dressing, and unfortunately, you got to call the doctor. That's right. I hope none of you tried to put it back on, because if you try to put it back on, you just became a plastic surgeon, and you don't want to do that. You're a nurse. All right, let's move on. If the client has a chemical burn, what do you do? Well, the first thing you do is remove the person from the chemical agent and begin flushing the chemical from the skin. Flush with water for at least 15 to 20 minutes. The same thing would be true if somebody had a chemical burn to their eye. You flush immediately with water. You don't want to wait until you get a doctor's order. You get some saline or sterile water and you hurry up and irrigate the eye so it won't burn through to their cornea. And don't forget, remove contact lenses immediately with chemical or facial burns. If it was a powdered chemical, first we want to brush the powder off the skin and then flush. Now, everybody knows the answer to the next question. If somebody had an electrical burn, there's usually going to be two wounds. And what are those two wounds? Entrance and exit, yes. The entrance wound is usually smaller than the exit wound. And anytime electricity comes through the body, it seeks the path of least resistance, trying to find a place to come out. So when it finds a place of exit, it usually blows that area out. So deal with the wounds that you can see. And remember, the exit wound is going to be bad also. So don't forget about the internal damage that you really can't see. Now, the next statement, if someone comes in with an electrical injury, what's the first thing you've got to do? Even if they're awake and talking to you, telling you that they're fine, what's the first thing you want to do? Well, you want to put them on a continuous heart monitor for the first 24 hours. Why do you want to do that? Well, they're going to be at risk for arrhythmias. What arrhythmias is this person at high risk for? Yeah, VFib, ventricular fibrillation. For the first 24 hours after an electrical injury, they're going to be at high risk for ventricular fibrillation. Now, with electrical burns, myoglobin from the injured muscle tissue and hemoglobin from damaged red blood cells can build up and cause what kind of damage? Kidney damage. Remember, we talked about myoglobin earlier being released when you have muscle damage. We see this complication most often with electrical burns, and that's why we worry about renal failure here. Now, it's not uncommon for this person to be placed on a spine board with a C-collar. Why? Well, it says on your handout, electrical injuries tend to occur in high places. They tend to occur in high places. So contact with electricity can also cause muscle contractions that are strong enough to fracture bones and even vertebrae. So consider a potential cervical spinal injury when someone has an electrical injury. Now, are amputations common? Yes, amputations are very common because the circulatory system is destroyed. They're common because the circulatory system is destroyed. Now, without adequate circulation in the leg, they can't keep their leg. They may end up having an amputation. Now, other complications of electrical wounds that we don't always think about are things like cataracts, gait problems, and really any type of neurological deficit that you can think of. Underline the word neuro. Anywhere there's a vessel, there's a nerve too, so nerves are damaged. Now, that's why it's not unusual to see gait problems, because nerves have been damaged, so don't forget about the neuro effects. All right, enough on burns.